Our next speaker is AARTI HEDA. She will be talking on Boramani's customized SICS.
And Dr. Aarti is a very young, dynamic leader with numerous roles to her credit. But she has been a great pillar of strength in ISM SICS. Please, ma'am.
Thank you so much. So, taking the discussion forward, we have spoken about incisions, we have spoken about astigmatism. So, I'll be talking on a very interesting topic. So, good afternoon, everyone. At the outset, I would like to thank Dr. Sahu and team AIOS for this wonderful opportunity. A big thank you to Dr. Boramani, sir, for allowing me to present his topic of Dr. Boramani's customized incision cataract surgery. So as we all know, cataract surgery has now become a refractive surgery, and the biggest concern with SICS is surgically induced astigmatism. So I'll start with a scenario. This patient with pre-op astigmatism of 0.13 diopter underwent a small incision cataract surgery. Post-operatively, patient had astigmatism of just 0.17 diopters. So is it possible to not induce any astigmatism with SICS? Let me show you another case with pre-existing astigmatism of 2 diopters who happened to be a VIP and wanted to get implanted with autofocus pro lens, which is a multifocal lens without any rings. Presently, they don't have any toric range of lenses. So other eye also had astigmatism of 2 diopter, and phacoemulsification was done elsewhere, and patient had astigmatism of 2 diopters post-operatively. So we decided to do SICS for this eye with the aim of reducing the pre-existing astigmatism of 2 diopter. So patient underwent small incision cataract surgery, and post-operatively patient had astigmatism of 0.43 diopters on topographer. Autoref showed the astigmatism of just 0.25 diopter, and subjectively the patient was 6/9 with plano glasses.
Next.
So the published literature shows that the biggest advantage of phaco over SICS is that the induced astigmatism is less, but there are no studies to say how SICS wound modification can lead to desirable results on astigmatism. The principle is very simple. A straight incision leads to astigmatism of 1.25 diopters to 1.5 diopters. When the incision is frowned, wherein the end of the incision goes away from the limbus, the astigmatism produced is 0.75 diopter, indicating that the more curved the incision is, the less astigmatism it will induce. So this is how one can titrate the incision against the pre-existing astigmatism. So after doing many surgeries in last 5 to 6 years, Dr. Boramani says that a straight incision of 7 mm will induce astigmatism of 1.69, and it will keep on going down as the size of the incision is reduced. So if the incision is frowned 1, the induced astigmatism will be just 0.5 diopter, and as you go on making it more curved, it will induce less astigmatism. So if it is perfect U-shaped incision, it will not induce any astigmatism. The temporal incision are away from the optical axis, so that they are not very strong in inducing or neutralizing the astigmatism. So a 7 mm temporal incision will induce astigmatism of 1 diopter, and a 5 mm will induce astigmatism of just 0.4 diopter. If the temporal incisions are curved, then they have no effect on astigmatism. So superonasal and superotemporal incision behave in between the superior and the temporal incision. So accordingly, you need to calculate. To have a better effect of incision on a steep meridian, you must center your incision on the steep meridian, irrespective of the shape and the size of the meridian, so that the vector forces are acting equally on both sides of the steep meridian. So the next question is where to sit for the surgery. Whatever may be the steep meridian, you will always get this half circle on both the sides. You can go inferotemporal or slightly superonasal. Operating from the nasal side may be difficult, but it's possible. But you can always fashion your incision on the steep axis. The SIA software can be useful to calculate your own astigmatism. You can put one type of incision in one meridian to find out your average astigmatism. So we will go through a few more cases. This patient had pre-op astigmatism of 0.28 and C meridian is 100. So the incision was taken at 100 degrees and it was extremely curved. So there was hardly any change in the astigmatism. In this case, the left eye was operated. The steep axis is at 40 degree. The incision was slightly curved, taken at superotemporal axis, and it had hardly changed the astigmatism. This is another case of a multifocal IOL. 1.62 diopter of astigmatism has just become the astigmatism of 0.29. This is an interesting case with astigmatism of 3.5 diopter, and the patient was not willing to go for a toric IOL due to financial reasons. A large straight incision was taken, and there was a significant reduction in astigmatism, and surgically induced astigmatism was almost 3 diopters. Her incision was almost 7.5 mm on the steep axis. So now we can stop calling it as surgically induced astigmatism and call it as surgically corrected astigmatism. And the technique should be called as customized incision cataract surgery. So thank you so much for your patience.
Thank you. Boramani sir, would you want to give some comments? Meanwhile, Dr. Nilutpara Devri from Shankar Deva Netralaya, Assam.
Only comment is you become master in SICS with a large and comfortable incision. If you are comfortable in delivering any nucleus through any type of incision, then you start customizing your incisions. Long term, actually in private practice it is very difficult. Many patients they don't come back after 1 year. It is very difficult to assess.
No, sir.
We have done the superior and temporal also, and the longer run, 3 months is taken as the cutoff point, but I have been doing 5 years, 10 years, whenever they come back, we do correct. And it's stable after 3 months.
In fact, sir, at 3 months, there's been an international study where the astigmatism it regresses up to 3 months, and at 3 months, there was a study where they did phaco against small incision, and the results improved. At 3 months, small incision performed better than phaco emulsification. And at 6 months,
here we want the opposite, no? We want that thing to stay there. So that
yeah, it stays. So what I'm saying, sir, it regresses and then it becomes stable. And beyond 3 months, between 3 months and 6 months, it becomes stable somewhere.
Okay. Yes, Nilutpara.
So these are the.
No,
I'm
we-